Welcome everybody to the Equally Well 2021 seminar series. This one's getting the most out of your GP. We've got some awesome presenters today. We've got Janne McMahon from Lived Experience Australia, Carolyn Robinson, who's a practitioner. Sorry, Caroline Johnson. I was just sitting next to a Caroline Robinson yesterday. Caroline, my apologies. Caroline Johnson, who's a GP and also works at University of Melbourne. Sharon Lawn, who is from Lived Experience Australia and also a professor at Flinders Uni, my old alma mater, and Sam Manger, who's a general GP and also the president of Australasian Society of Lifestyle Medicine. I'll give a proper introduction as we go through each of the visitors. Before we get into our first presenter, which will be Dan, I'll just do a little bit of housekeeping. So for those who've not come in, if you hover your mouse up the top, you'll see the view options. Click that downward arrow or chevron and click that to fit window, and then you'll be sure that the slide presentation fills your window correctly. If you've got any questions, just down the bottom, if you hover down there, there's a Q&A. I said the chat before, that was an error. Go to the Q&A button and you can have any questions that you want to make to any of the panelists and through me. If we go to the next slide, thanks Lee. Just before we get started, a few ads. Just to tell people a few things. One is that we have our conference coming up in Thursday and Friday, the 12th and 13th of August on the Griffith University on the Gold Coast. Now, our last conference in 2019 was awesome down at RMIT in Melbourne. And as a result of that, I encourage you to go there. We have a book of conference proceedings, and that's available on our website. And I think if we put it in the Q&A, Lee, if you can put the links to these conference proceedings and to see the sorts of awesome presenters we had last time. But also, if you go to the Equally Well website, which Lee will put in the Q&A as well, there'll be the guidelines if you're interested in presenting or attending. This conference is free through sponsorship and the generosity of Griffith University and Charles Sturt University. So it's free to attend. And because it's really important for us that it's an inclusive event, that it's just not for rich university professors and health professionals, that consumers, carers, and anyone who wants to, has an interest and a passion for this area can attend. So it's just to add on that. Also, if you're interested in being involved with any of the bulletins, newsletters, or Lee will also put in the Q&A our social media, but also to email Lee at inquiries@equallywell.org.au, and Lee will put that in the Q&A as well if you want to be notified of any upcoming events or updates in things to do with Equally Well or the physical health of people living with a mental illness. And there's a lot happening. One last ad, those of you who are leaders in mental health, that we are looking to have an Equally Well international leadership match. And that will be, let us know if you're interested in participating in that. We'll have a few webinars and God willing, meet face-to-face internationally in New Zealand in February and March 2022. But if you're interested in that, reach out to us and we can send you information. And Lee might even, I'm putting Lee Cobb on a lot of pressure here, put in the link to the IML, the International Initiative for Mental Health Leadership, of which Australia is a member. I think that's all for the ads. Once again, if you've got any questions of us at Equally Well or the panelists, well then by all means just put it in the Q&A and we can throw that through to the speakers. I think that's enough for the advertisements. So welcome everyone. Our first speaker, and this is such an important area, and now that I've had a look at the slides, it's even more important. And we have a really esteemed panel. I'm so impressed and so thankful for the panel for participating today. Our first speaker is Janne McMahon. She OAM, Order Australian Medal. I don't even know this. I'm sorry, Jan. I don't want to embarrass you, but you have to tell me what OAM stands for. But she's the chair and executive officer of the private mental health consumer care network in Australia. She's worked in mental health for a long time, since 1997. She founded the network. It's a recognised peak in Australia in terms of mental health advocacy. She's appeared before numerous parliamentary inquiries and advisory, and is on a number of government committees and advisory groups. She's also on the board of the Mental Health Council of Australia, and along with all sorts of other roles, she's also the patron of the Australian BPD Foundation. And in 2008, and I've worked this out now, she was awarded the Order of Australia in recognition of her advocacy work in mental health. So it's my great pleasure to introduce Jan, and I'll hand over to you. Thanks, Jan.
Look, thank you, Russell, and thank you very much for that introduction. There are a few things that I'm not sure where you got that bio from, but there's a few things that have been updated and changed, most particularly the name and the title of our organisation, which has gone to Lived Experience Australia. And after the length of our previous title, you can see why we made the change. So thanks for that. Look, I'm coming to you from a very practical perspective, and so I only have the one slide, but I'll go through the 7 areas that I've put there. And so it's a bit of a tip sheet, I guess, from that practical sense. So we know that COVID has changed a lot of the things and the ways we have done things, including visits to our GPs. And we know that many GPs switched to telehealth, which was fantastic. It still enabled that connection, whilst we're unable really or had less opportunity to see them face to face. And this is now beginning to change as COVID is really being well contained. So what I'm hearing from GPs is that they're noticing that people are coming to them with a lot to be covered. So they're not getting the quality time with their patients that they want to cover all the issues in a single appointment. We're seeing our GPs more stressed these days, as people may have seen them more regularly prior to COVID, and now they're coming with quite a number of different issues, including an increase in anxiety and depression, which we really need to see our GPs about. So given that the GPs are the first and most accessed and accessible medical profession, they tell me that they really want to make sure they can give the very best care possible. So here are some very practical suggestions. Make a list of what, in the days leading up to your GP, we know that you want to go with a particular issue, but put a list of things that you want to actually talk to your GP about. I do this quite regularly, and my GP kind of says, are you coming through with your list again, Jan? And I said, yes, but at least it'll keep me on track and I won't be all over the place. So I think it keeps you targeted on what you want to say. And I think that's a really important point. I'll be interested to hear what the GPs on the panel say if their patients come in with a list, but that helps me anyway. I think the other thing is, do we need a prescription renewal? I think one of the difficulties is if we see our GP and at the end of the appointment we say, oh, by the way, I need a prescription renewal, please. And if it's one of those authorisations that the GPs have to phone through, that can take a significant amount of time. So if you really want a prescription renewal, put that right up front. So in terms of the list, provide it to your GP as you walk through the door, more or less. That way it will means that you can cover everything you want. Your GP can look at the list and can then prioritize the things that they consider are more urgent and need to be dealt with first. And if you can't get through that list, then they can say, well, let's discuss this priority or this urgency now. The rest we can talk about at a later time. I think it's also really important that if you can't get through everything you want to, and that's fine, we know that the GPs have got a waiting room full of people, so they're under the pump a lot, and that's creating quite a lot of stress for many. So once you've talked to your GP, they will say, okay, well, let's make some follow-up appointments so we can deal with some of the items that are still on your list. And that way we can all be sure that even these low priority items are really addressed in a timely manner. Make a double appointment if your GP thinks that's the way to go. So that if you want to talk things in more detail or to discuss something that's more complex that's really worrying you. If you feel this is the case, ask for that double appointment with your GP just to make sure you've got enough time. And that double appointment really does give you that, and it doesn't hold up the GPs for other appointments, with people in the weight room. They know that, right, we can talk about this, let's make a double appointment and we can go into far more detail about the things you're concerned about or the things you want to that you're worried about. The other thing is, be courteous. If you can't make your appointment, and oft times it's unavoidable, but just make sure you let your GP's practice know, and as soon as you possibly can. That way, if you can't make an appointment, they can reschedule and pass that opening on to somebody else. We have to remember too that many GPs, they work as small business operators. And so we have to really be mindful that if you drop out, then there's two things. They could potentially offer it to another patient, or it is a loss of potential income for them. And I think the final tip that I'd like to provide to you is be understanding. Be patient with your GP and their practice. Everyone knows that things are changing and new processes take time. So I know that I have a GP, sometimes the wait times are incredibly long, and people tend to ring and say, well, how far behind is he or she? And that's fine. It's very hard to itemize and time a particular issue when you don't know what that issue of a patient is. So, even though your GP has a lot of patients to see, each individual patient is really important to them. You really matter to your GP. So having a plan and a list really makes it easier for them, I think, and to make sure you get what you want out of your appointment. So I hope those have been some reasonable suggestions and tips. I hope it helps you in a practical sense the next time that you make an appointment to see your GP. So thank you, and thanks for the opportunity, Russell, of presenting.
Jen, I'm wondering from your perspective, or perspective of people in lived experience, and this is the whole point. One of the big points of Equally Well is that people go to the GP. Often the GP is talking all about their mental illness because that's what they see and they're worried about that. But in actual fact, I was just doing some data for some people the other day, and every day, 16 people living with mental illness in Australia die prematurely of cancer. The population rate for Australia is 2 people per day. So we're sort of 8 times more represented than those early deaths. And part of that is, and despite the fact that the incidence of cancer is the same for people with mental illness. So this is one of the things that's really tricky. We call it diagnostic overshadowing. So, but these are things we don't know about, like we should be asking about. Might be a question for the GP to respond to a bit later too, but what would your advice be around making sure that, that chronic physical health conditions or things that you should be screened for, what's your experience and understanding of how that works in respect to that challenge of diagnostic overshadowing, where the GP focuses, which is fair enough, person's coming with a mental illness and they present that to the GP and the GP deals with that. What would your advice be to make sure that, those other components of your health are also not being overshadowed?
All right, so I think there's two things in there. I think that the GP practice, if they're really on the ball, will have recalls for things like it's time for a colonoscopy or a breast screen or something along those lines. And many GPs are doing that as a matter of routine. So that's really important. And if your GP is not, then I suggest that potentially you ask if that can be part of your health care, not only mental health care, but your health care. But I think the other thing that's important is if you're making your list, talk about aches and pains or, whatever, because when your GP has a look at that list, he or she could say, right, well, this is potentially mental health related, but oh gosh, well, this might be inflammatory bowel disease, which could be caused by your anxiety. So it's important not only to treat your anxiety, for example, but also treat the inflammatory bowel disease. So we have to trust our GPs, but I think it's absolutely appropriate that if you go to your GP with a list, then you will be able to highlight to your GP that you are having some physical issues, and your GP can look at that list and say, right, well, that's mental health related, but we have to do some tests or some follow-up in this physical aspects. So I think that would be two things that I would suggest to people. Whether the GP, and I'm sure Sam and Carolyn will be able to say whether, this screening, regular screenings, etc., is it within the capacity of a GP practice? I know mine does it. Whether that's something that GP practices can routinely do, given whether they have the capacity, not whether they want to, but whether they have the capacity to do something along those lines.
So I think with the list, Jan, from what I'm hearing you say, one of the things you might add on the list are there any screenings that I'm due that you would recommend that I should have at the moment? And I'll ask Lee to share this link too. Some of the work that one of our Equally Well committee members have done and published recently is about vaccine preventable hospitalizations and vaccine preventable deaths. So the other question might be, are there any vaccinations that you think would recommend that I'm due or that I should have? But I suspect Caroline is champing at the bit to sort of enter this discussion. So I'm going to introduce her. Caroline is this wonderful person. I've worked with her for a long time. She's got this great practical view of GP practice and with the really lovely, I think, combination of the practicalities of practice with the research, but also just a beautiful, warm heart. She works as a practicing GP. She's also on the college. She's a college representative on the national committee and on a lot of other things. She's published as a GP researcher on depression and mental health treatment. She's on the Royal Australian College of GPs Expert Committee on Quality Care and also a board member of Mental Health Australia. So she brings so many things to this. And I know with some of the research I've done, the insights that she has about working collaboratively from a GP's perspective are just golden. So with that very low-key introduction, Caroline, I'll throw to you. Welcome.
Thanks so much, Russell. I really appreciate the introduction. Some of those roles are former roles, not current roles, but that's good to acknowledge. I've been around a long time, so you do collect a few of those. So thank you, everyone, for having me here today. And I'm going to perhaps shift a bit. I think Jan's recommendations are excellent, and I agree with all of them. I'm going to shift a bit more for those who are the skeptics in the audience, because I know there will be. General practice isn't perfect. I just want to share a few thoughts particularly about how to work with general practice if you're a professional, like a health professional, you're trying to work. But I think this information will be very relevant for people with lived experience and carers as well. So first of all, I'm sharing this document. It was published in 2008, so it's getting a bit old, but I would say of all the documents and policy things I've ever read in my 20 years of mental health advocacy, this is my favourite. I was at the launch of it at the WPA Congress in Melbourne in 2008, a document World Health Organization and Wonka wrote about why this is important, with lots of case studies from all around the world, from countries who have much weaker mental health care systems than we do, which really can give us hope and convince us that we can do this in general practice. And particularly it's relevant to the equally well space. In fact, I think it's one of the strongest arguments of why mental health care needs to be integrated into general practice care, is because people don't come with separate problems. They're a whole body and they're a complete person. So we do need to think about how we combine and integrate physical and mental health care. We don't want to carve it off. And of course, all the other things that many of the people in the audience already know. This is a human rights issue. Time and time again, this is the group of patients, the equally well cohort, the ones with the worse health outcomes. They're the ones who don't get the care. And I think that's a real concern for all of us if we're seeking an equitable society. Please move on to the next slide, Lee. So the other thing, if anyone's not convinced, philosophically, general practice is very much a relationship-centred profession. So we all like to say in our profession that Hippocrates was the first GP. Maybe he was, maybe he wasn't. But this sentence that he said about knowing the person who has the disease rather than the sort of disease the person has is absolutely key to the way GPs work. Next click, Lee. And that's because we are trained in the biopsychosocial model. And Russell's absolutely right. There is a risk of diagnostic overshadowing, of focusing on the biological. But actually in GP land, we actually like doing all three. And the more experienced I've become in this, the more I realise that actually dividing people up is a very Western-centric kind of way of thinking about the problem, and trying to integrate what we know about biology, the way you think, your psychology and your social environment is absolutely the cornerstone for us. Next slide. So I'm now going to talk about integrated care, because I think that's something that'll be I can contribute usefully. How do we all work together to solve this problem? And the puzzle here is not the patient. The puzzle is this health gap. Okay, so the first thing I want to say is the most important person in this circle is the person with the lived experience. And certainly as a GP in all my years of advocacy, I always feel at these meetings much more aligned with the lived experience people, because I'm kind of there every day over many, many years hearing their experience, and it matters to me because I often live and work in the same communities that they do. So I feel very connected and passionate about that. Next slide. But it's important for everyone to realise that GPs do collaborate with an awful lot of people. So here's a list I prepared earlier of all the people that I might interact with who are also health professionals. And I think that's a unique place GPs sit in, that we actually interact regularly with all these different people. Next slide. So if you're in the mental health system, you can see you're only a small fraction of this. So use the GPs as a resource. Don't see them as part of the problem, and don't just send people to GPs to get things done. Actually think about how we have this expertise already of working with all these different groups. Next slide. And I also made a little list of all the people I could think of off the top of my head that I've interacted with in the last 10 years that aren't health professionals. Some of these obviously have health professionals involved, but so many different programs, so many different opportunities. This creates a real potential for good outcomes, but it also creates a potential for a lot of fragmentation, which is again something GPs feel absolutely passionate about. Next slide. So this is what we call the silo problem. So if anyone who's from a health professional background wants to take one thing away from my bit in this webinar, is we need to always think about how to break down these silos, how to improve communication across all these different things. And I think primary care can help with that. But really from a GP perspective, most of the systems that are designed by the health system actually increase silos and increase fragmentation. And that's what really makes GPs grumpy, because they're often asked to just write a referral or fill in a script without actually being inclusively involved in how to make it all work together, even though we think we're skilled. So next slide, my last couple of minutes. The wonderful manifesto I introduced you to at the beginning of these 7 minutes, this World Health Organization and World Association of Family Doctors document, actually comes up with these 10 fantastic principles. And I'm going to highlight the ones that I think are particularly useful to talk about today. Next slide. So first of all, the training myth. I started my career as a medical educator training GPs. I absolutely believe in it passionately, but everyone needs to acknowledge that just throwing more training at GPs who have already spent 10 to 15 years getting the qualification in the first place won't address these rapidly changing needs that our population has. We need systems that make it easy to access information at the time you need it, and not just think that if we just throw more hours of training that somehow will improve the system. Next slide. About how specialist mental health professionals work with us. Really important to think about, are the other mental health systems making it harder or easier for GPs to have that continuity with patients. And we can talk about that if people are interested. Next point, that having a coordinator to this mental health system is absolutely crucial. And very recently in the Lancet, an Australian trial called Link Me was published, which actually shows that for this group with more complex mental health problems, having a bit of extra help, not just the GP, but someone else to help make sure all these dots are joined up, does actually improve outcomes. And I think it's a really exciting area where Equally Well needs to be doing more research. Next slide. I'm almost done. I just thought I'd do a little bit about communication. We often talk about communication as this amazing technological thing that, you know, these health records and everything will fix. Actually, communication doesn't really look like this in my world. It looks more like this. The next slide. It's often kind of very piecemeal and a bit erratic. And while I love technology, I think technology needs to be applied in a way that keeps in mind the human beings and the relationships that we need. So I can definitely apply technology much better to patients that I know really well, who I've seen over time. So please remember, when you're saying to someone, if you're a health professional, you say you need to go back to the GP to get these tests, encourage them, even if it means waiting a week longer, to see a GP that already knows them, because then the GP is not starting from scratch every time. And please make sure, if you give some advice to a patient, put something in writing, even if you print it off and give it to the patient to give back to the GP. We consider you as mental health professionals as experts in the field who should be educating and upskilling us. And if you don't share with us ideas at an individual patient level, you'll actually miss out on a lot of opportunities. Similarly, think about how the system works in terms of safety of communication. So avoiding email, which is not secure. Obviously, that had to change a bit during COVID, but thinking about secure messaging. And then my last slide. If any of you want to be more inspired about GPs, please consider going to this website, gpscan.com.au, a group of passionate GPs who want to increase the optimism even within the health professions about choosing GP as a career choice, have created some lovely slides with the voice of people with lived experience of what they can get out of their GP. And if you need any more convincing, that's the place to go. Thanks for your time.
Thanks, Caroline, for getting through so much in such a short amount of time. There's a couple of questions that have come up in the Q&A that I think you could see. So if anyone in the panel can respond to it, but I will just check and with a couple of things with you. When I looked at that thing, it was like an epiphany for me to say, wow, you know, when you're moving things around the thing, there's GPs moving all these pieces around. There's so many different components and so many different organisations, and a lot of the people attending this webinar will be also providing services. And what would your advice be from a GP perspective to sort of better coordinate those elements of the system?
Yeah, so one thing I would love to see is less complexity in the system. I know maybe I'm a Pollyanna saying this could be done, but every time an external organisation creates a system, it creates a new cognitive load for GPs. So in our state, one example of a solution was the Victorian statewide referral form, so that everybody agreed to use the same form and asked GPs to put the information on the same thing. But you know, during COVID, I've got at least 3 new systems that I can only access by creating a new login to a new process, SafeScript, or even to do a death certificate now, I need a new login. So the more uniformity, the more those systems use the same process to get the GP in the front door, the better. And similarly with the feeding back, every hospital, every provider has a different way of providing information back. It often doesn't come securely. It often comes with a lot of data, like a lot of printed words, which can take you ages to get to the point. So for example, a hospital discharge summary that has about 5 pages, and the most important thing, which is we'd actually like you to arrange these tests and follow this up, is buried on about page 5, all in the same font, very hard to see. You know, when you come to work in the morning and you've got 20 emails like, or 20 messages like that to read, the visibility of the important information is so important in designing referrals, and the uniformity. And certainly that's at a national level, that's where the College of GPs exists, to give people that advice of how to make it accessible for GPs, make it easy for GPs to work with you.
No, that's great. There's 2 other questions. One I'll throw to the general panel to just think about, and you're welcome to come on to it as well. And the other one, also particularly to you and Jan, We've got a question from Victoria Palmer, who is the Chief Investigator for the Special Interest for Mental Health. So welcome, Victoria. And as everybody knows, the physical health of people living with mental illness is one of the key components of that new special interest research group that's just been awarded about a month or so ago. But her question was, and I'll start on this, but then throw to the rest of the panelists very quickly. Are there any tools around care planning, etc., that you're aware of? I'm aware of this actually comes back to what you were saying, Caroline, is you talked about the fragmented system. Well, every jurisdiction has their own set of tools. So that in mental health specialist services, they have their own guidelines and policies, and behind that are algorithms, which will say, test X, Y, and Z. And if it's in this range, it's sort of moderate high risk range. So I do understand that New South Wales is having a new version of theirs due to be released very soon. Someone from New South Wales is online. You might be able to update me on that. It may have already been released, but a month or so ago, it was imminent. So I'm aware of those. Also, University of Western Australia and Western Australian Mental Health Commission did a wonderful job. It's a little getting quite old now, but in terms of having tools for consumers and carers and clinicians, and that's still available online. I think it's about 2008 to 2011, but it's a really nicely presented package. We're hopeful that through Equally Well, that some of these things might be put together and standardised. So that's my first response to the tools to help care planning around physical health for people with mental illness. But I might quickly throw to the panelists if you're aware of any other online tools that might be helpful.
Hi, Russell, it's Sharon. Some of the people in the audience may know and have heard about Flinders program tools, which are generic tools. So we're actually just finishing an RCT with community mental health services here using the Flinders tools with care planning for people with mental health and cardiac issues. They've been used quite broadly. They were fundamental to the Coordinated Veterans Care Program, which is part of general practice as well, and used with Indigenous populations as well.
Okay, no, that's great. Thanks, Sharon. And Lee, I might ask if you can do a quick search for that and find the link to that and put it in the chat box so we can save it as part of the chat.
Could I chip in there?
Sure.
So certainly in GP land, there have been many attempts to get chronic disease management plans better integrated. There's a group, for example, CDMNet, and they, GPs could subscribe to it, and they could. My practice doesn't use it, so again, you're often limited by the practice you work in. Remember, most GPs are contractors, so their practice decides what's on offer, and then the GP has to work with whatever's there, and they just get a percentage of the fees that they generate for the practice. So that model doesn't make it easy for GPs to be nimble and adopt different systems. But what I will say is the biggest barrier to those is there's often too many tools, and often the tools don't actually address the underlying problem, which is the way it's funded. So if you've got a serious mental illness and you need mental health care and physical health care, the GP's got this dilemma of, well, do I do a mental health treatment plan? I actually get paid a bit more, but it takes a lot more time. Or do I do a chronic disease management plan? Sometimes you can't do both because Medicare will reject one or the other. So often the limitation to these tools is not the tools themselves, it's the lack of uniformity, it's the access across all practice platforms, and then it's the way that we're funded and incentivized to do the work that we know we need to do.
Great, thanks, Caroline. The other question I'll leave on notice for after I think Sharon and Sam have presented, because it's so important, and a lot of it is around trauma-informed care and dealing with the capacity and the training of GPs about dealing with trauma related to mental illness as well. So I'll just put that one on notice, and we'll come back to that one because it's a really important issue. In the interest of time, though, I'll keep moving on. So it's my pleasure to introduce Sharon Lawn from Flinders Uni. As I mentioned, that's my old stomping ground. Professor Sharon Lawn is a lived experience researcher at Flinders Uni in South Australia. Awesome views. I imagine the weather down there now is glorious, the lovely Adelaide autumnal weather. She's a deputy chair of Lived Experience Australia. She's previously been the director of the uni's psychiatry research unit for about 5 years. She works in mental health and aged care and disability for a long time, scores of years. And she's also led a lot of research projects. Anyone who could just sort of Google Sharon will see the number of research projects she's been involved with. Really, they involve a lot about implementing health system change, and her research focus has been on self-management of physical health and mental health, but also, as she's already alluded to, some work with veterans and first responders. The other thing which I think is particularly important is the role of peer workforce and the service users and family perspective and addictions. She's got hundreds of publications and been awarded so many grants. It's envy of many of us academics, Sharon. And she's, not, as well as being a researcher, she's also talking today as a carer. So you notice today we've got someone with a lived experience expert, some GPs, and a carer's perspective to give a nice perspective of working with GPs. So welcome, Sharon, and it's over to you.
Okay, thanks, Russell. It's a bit odd for me because the term carer doesn't sort of quite fit very well, because it's in relation to my husband, who I'm his wife and he's my husband. And so that's the context that I always come to. I guess, you know, to give a bit of context, we've been together for nearly 20 years, and the GP has been very much a part of our lives through all of that time. We've been with the same practice, and the practice has changed a great deal over that time as well, from being a very traditional single GP practice with a receptionist to now being a multi-D practice with a whole range of other disciplines with access. So my husband has a number of mental health conditions, but also a number of physical health conditions that require ongoing care. He gets depot medication from his GP as well. So he has a very regular contact with the GP. So part of what I wanted to sort of stress today, talking perhaps to other carers and in particular, is, you know, how we navigate our journey with the GP. So because I'm always balancing, you know, that real respect for my husband's autonomy and his capacity to do things, and the importance of him doing things for himself as much as he can. I always check in with him. I always, you know, we've been doing this together as partners for a long time, but, you know, every time we go to a new specialist from the GP referral, well, you know, I always ask, you know, would you like me to come? I'm the driver. I often sit in the waiting room or in the car, but invariably he asks me to come in the room with him to help explain, give history, so he doesn't have to repeat his story, so he can find the words, etc. But I always ask him in that. And we usually always, you know, it's just an ongoing part of the conversation. Yep, prompting, you've got, oh, yep, you've got that appointment coming up, and talking about, you know, what he might need to cover, what he can discuss with the GP, just helping him remember, I guess, what are all the things that he does want to do. Sometimes we write a list, Jan, absolutely, because invariably, you know, it's about that prioritising, organising the time, because it is very short when you go and visit the GP. I guess, you know, to build on and not replicate what other people have already said, I thought I'd talk about some of the things that personally don't always get onto sort of information. And the thing that resonates really for me is that every time that I go to the GP with my husband, what I'm doing is showing the relationship. I'm showing the person to the GP and to the staff at the practice, because they are important people in our lives. They're regular people in our lives that help me and help everything keep going. So so it's not hard for people to like my husband, but it's my role to show them who he is, and for them to like him too, and to understand him, and through that trust gets built. So I'm really conscious that that's what I'm actually doing as a family member. And what I'm doing, I'm teaching the GP how to engage, to model the shared communication. So we've all been to places where as soon as they identify that you're a family carer or whatever, they'll start talking to you and not even look at the person, and they'll start talking to them in the third person. So, I very calmly and quietly knock that on the head and absolutely model how my husband and I would like the communication to be, and he responds to that as well then, because it's his care. It's important for him to have that relationship with the GP as someone that he can trust and go to. We've experienced a whole lot of different versions of general practice business models. Increasingly there are prompts and feedback, follow-up sort of texts, etc. But even in our most current system, which is very business oriented, a new company has just taken over the practice, and it still has the same amount of hiccups. So what I would say is absolutely, as a family member, still keeping an eye on the diary, all of those things, still checking the history, the referral letters that invariably still have medication doses wrong, still have history points wrong sometimes. So, it's being that person that holds the history and holds the story for the person. That's part of what I see in my role. The other thing that I do notice, and it's very hard sometimes for family members to, because we're fairly vigilant people, and what impacts a person impacts us, and sometimes when you're seeing different GPs or people that you don't know and they don't know you, is that particularly the staff, as you're coming into the GP, they don't always grasp why it is that you might be concerned about something. So, I had this happen recently where, it's a fortnightly appointment. It's a fortnightly appointment ongoing. It should be obvious. It's in the diary for them. Why can't we make a fortnightly appointment for the next 6 months, etc.? It's not something that's going to change for my husband to have his depot. What they don't grasp is what happens when that drops off the diary. The consequence for the person and for family members can be pretty scary if the person becomes unwell. And so they're not going to understand that, because that's not in their daily field of vision. That's in your lived experience as a family member and as the person. But in general practice, the staff may or may not fully grasp that. So you can't just change tack. You can't just say, oh, well, you missed it this week, maybe you can have it in 2 weeks' time. It's those things. So the communication Carolyn picked up on, we've experienced a range of different types. We've had fantastic periods where we've had a psychiatrist, GP, regularly sharing communication with each other. And we've had times when the GP has absolutely been the most pivotal person in that communication and the holder of the care, really, because we've had fragmented care in other parts. Next slide, Lee. So I was thinking, and Russell had prompted this question when we caught up recently, of, what advice would I give to mental health providers in helping carers to connect with GPs, and to try and think about things other than the usual things that Janne has talked about. If I was a mental health provider now and I was talking to family carers, I'd be absolutely emphasising to them to be organised, visible, known to the GP and the staff as well, because it's not just the GP, it's also those front desk staff that really can help make some things happen. If you're a vigilant carer, but also being prepared to navigate, because you are the glue, the communication glue. Systems do fall down, systems are siloed, as Carolyn said. Sometimes misinformation or inaccuracies can get through, so you're the holder of that. The other important thing in that is, not getting uptight, not getting frustrated, which has already been covered. It's that walking alongside rather than leading in the partnership, because it's not all about you as the carer, it's actually about the person going to see their GP. So they're the priority, it's their communication, their contact. So I'm in the background. Sometimes I step further forward, sometimes I step further back, but I always negotiate that and navigate that with my husband, depending on what he wants and needs at the time. So part of that is that it's that respecting their privacy with the GP as well, because there may be things that they obviously share and want to share that are not my business, that may not be anything to do with me and our relationship. Understanding the business model is about that, and that they don't necessarily understand the whole part of what your needs are. The other important things are, for me, the way I've always looked at it is that the GP is an ally when it counts. So my husband has levels of paranoia and delusions and psychosis and all those things. And I can think of the times in our lives when the GP has been the only person that he has trusted to go to, when he hasn't actually trusted to go to or make any contact with mental health services. So the GP is absolutely an ally when it counts, particularly in those circumstances. And the other, the frustrating thing that I'm sure a number of family members experience, I can bang on about things repeatedly, but as soon as the GP says exactly the same thing that I've been saying for a long time, it's new information and the person engages with it. And so, GPs are very useful people. They stop you from sort of repeating yourself and getting frustrated as well as a family member. And they're, if you think about it as a family member, then, the GP and you can become good allies in reinforcing good messages around what's actually needed. The other nice thing, and Carolyn really captured this when she said it was the whole body and a complete person, something we've always experienced, which is different to other parts of health services, particularly for mental health, is the GP hones in physical health concerns that the person sees as the priority. So in every visit that my husband, it's not about how's your mental health today, it's always about how are you today, which is really, really quite nice. It's very practical and compassionate. So the GP will always see the person beyond the mental illness. And that's probably where I'll leave it for there, Russell. Thank you.
Thanks, Sharon. I mean, that's a fantastic extra perspective. And one thing I'll pick up on is, you know, that in all relationships, there's often communication hiccups. Doesn't mean the other person's failed or is bad. It's just communication hiccup.
Yeah, it just happens sometimes.
Just happens, and approaching that as, you know, the world is not perfect, and sometimes there's hiccups, and just accept that as far as possible, and as you said, continue to build and strengthen that relationship. I'm interested a little bit if you could unpack a little bit more. The couple of points you say about walk alongside and then respect the autonomy and privacy of the other person's relationship. I think that's quite profound in terms of sometimes I imagine that if someone doesn't do that, you can actually undermine that person's sense of autonomy and self-agency. And so just wonder if you can unpack that a little bit more for us.
Yeah, absolutely. And, you know, I think what you've just said actually captures the reason, because, you know, when I think of my husband, he has to, you know, he's got all these appointments and all these health issues, and I'm sure he gets tired of taking tablets, of seeing people, and so the last thing he needs is then for someone like me as a family member to come in and barge in and take over, you know, where he doesn't even feel that he can be part of the decisions and the speaking around that. So, you know, and then the impact of that on then him is that, you know, it affects his self-esteem, and he just would feel like a passenger, and that's the last thing I want, because, you know, this is our lives, this is our, you know, this is a relationship. So that's why, you know, it's making sure that he is absolutely included front of centre, and that those other people treat him in that way, I think.
The other thing I wanted to explore with you, I remember reading some of the research literature, in fact, it might have been one of your publications, about what carers often are excluded by specialist mental health staff from the carers if they wouldn't know anything, and they'll get in the way of the care planning. Which is, you know, problematic in so many ways. But so what advice would you give to sort of specialist mental health workers in helping engaging the carer, but also particularly getting the carer engaged with the GP in terms of the physical health of the person that they, you know, have that connection with?
I guess what I see among my family member peers is, you know, a lot of people experience feeling shut out, being left in the car, sitting in the waiting room, and that only actually heightens their anxiety for the person, and because, you know, the consequences are not just for the person, they're for the whole of the family, and so. And family members, carers can see, you know, they can see what's coming, and they can get anxious. And so if they're shut out, they'll become pushier, they'll become more anxious, they'll become more vocal, and they'll step in where they actually didn't want to step in. And that, you know, it frustrates them that they have to keep banging on sometimes. To, you know, because they're worried that things will get missed, and they're worried that that the care will fall in a heap, and at the end of the day it's them that picks up the pieces for that, that's, you know, bears the consequences for that. So that's their vested interest in making sure communication happens. So, you know, my advice to any health professionals is, if you understand that about what drives the family members' concerns, then you would work with them and you would ease their anxiety, and they can become incredibly productive allies to health professionals, whether GPs, mental health workers, whatever.
Yeah, it's an expertise that's too often unrecognised. It's a lifetime of experience, or decades of experience that just brings a wealth of knowledge that a short consult can't possibly sort of capture that long-term history. Thank you. I think it's very profound, and what you've said in terms of and the importance of the carer. And I must say, I have met your husband, and I agree. Your assessment is not biased. I'm sure it is biased, but certainly from my perspective, thoroughly likable and lovable man. It was just such a pleasure to spend some time with him. So, and thank you for sharing some of your life story as well. We've got to keep moving. Just before we do, I'll just flag with the Q&A. Some of the panelists, often I just put a dot there, and what that does is put the Q&A live so everyone can see it. All the attendees can see it, including the panelists who might respond, type a response. As far as possible, I'll try and put some of these questions verbally to the panelists as well after Sam's presented. And on that matter, I'd like to introduce Sam. He is a degree in medicine from UQ, and he's also a GP in private practice in rural Queensland. He's a clinical research fellow at the Mind and Neuroscience Institute at the Thomson Institute I presume that's the one that's on the Sunshine Coast. He's a senior lecturer and medical educator with James Cook Uni. I don't know which one that is, the Townsville or Cairns one or another one. There's also at the College of Medicine and Vocational Medical Officer with Queensland Health, and also the host of the GP Show podcast. And if you haven't done so already, Sam, maybe in the Q&A, if you could post the link, or Lee might be able to post the link to that podcast, because it's great. So I highly recommend you tune into that podcast that Sam does. And he's full of energy and enthusiasm and innovation. So it's with much pleasure we introduce Sam.
Yeah, thanks. Thanks, Russell, and thank you, everyone. I just quickly acknowledge all the really good questions that are coming up in the Q&A from everyone. Kit and Anne-Marie and Dave and all the others. They're really excellent questions, and I hope we get some time to get through them. So there's really, because we haven't got much time, I'm going to set my timer, and I do want to get into that Q&A. There's only really two things I thought about in this, and there's lots that could be said. One is the sort of idea of whole of person care, which has been mentioned. So I'm going to be repeating some of the things that has already been said, but just maybe a little bit more detail. And the second thing is how we can work together, i.e. GPs and people with mental illness and or allied health, etc. But in particular, this idea of creating excellence of care through empowered partnerships. So how can we improve all the people within that partnership? Because as you can see from some of the comments and questions, there's clearly deficits in the healthcare system. I think we can all and should all acknowledge that straight from the get-go. Now that may be deficits in training, but it's usually typically deficits in the actual structure that limits everyone. And we all therefore need to come together, contribute, problem solve, brainstorm around that. So how can we do that? Next slide, thanks. So just quickly on the whole person care, because this is where one of my areas of real passion, in the sense of seeing people, as has already been said, not just as a diagnosis or with a mental illness or even just a physical illness. There's a social component, there's a past component, whether it be genetic or childhood, etc. There's a spiritual component, there's a cultural component, and it's so important that we do that. So as Carolyn has said, I think that to be a great GP is probably one of the hardest medical professions or specialties there is, if not the hardest, because you've got to be so good at everything. But it's not that hard to be an average GP. So if you can find a good GP, and which there are many, then use us for all that we're worth, because there is a lot, as Caroline said, that we want to help you with. Now, the challenge here is really the system. It's not necessarily the GP's passion, interest, or even skills or training. It's just these silly 15-minute appointments that we have, the high pressure, the ridiculous volume of paperwork and everything else that we have to deal with. And that takes away from patient care. So just be aware that it may not, I know that I am imperfect frequently. And it's typically because I'm either under the pump, pressured, distracted, and running late, etc. And I see one of the comments there about GP should never run late. I think your GP is amazing. The fact that he's never run late, that is certainly not the truth for me. if a patient needs my time, if they say, you know, in serious distress, then I will give them that time. And if that calls me to run 25 minutes late, I will run 25 minutes late. But this is just the way that the system operates. So just be aware that that is the system we operate in, but we're all trying to improve it. The way to get around that is simply to develop that relationship with your patient, with your GP, or vice versa. Book double appointments. So just know that maybe today I'm only going to have 10, 15 minutes, but book that double appointment for the future and say to the GP, I want to discuss all of these things. And that's why I'm going to book double appointment. Even tell them in advance, you know, with the single appointment, so that they can prep. And stay in contact. One of the major concerns or problems I have with a number of patients with chronic, whether it be mental or physical disorders, is they just disappear for 6 months and come back for their next script 6 months later. And it's certainly my job as a GP to organise follow-up, but it's also the responsibility of the patients. I know that word isn't as commonly used these days, but I will use the word patient. To organise some follow-up. And I would recommend to a lot of my patients who really want to make significant progress on the whole of person care that I actually like to see them every 2 to 4 weeks for a number of months, so that we can really get deep into the issues at hand, really get a deep understanding of the factors that led to that, and really get a good idea as to the facilitators and things we can do to overcome that. Next slide, thanks. So just to give you context of what I call lifestyle medicine, which I don't call it, but this is the term, lifestyle medicine. And just to be aware that when it comes to whole of person care, it's got a huge role to play in mental illness and physical illness. Now, we all know, I'm assuming most of us will know, that diet and exercise have a big role to play in, say, preventing or reversing diabetes or obesity or the other sort of, or cardiovascular disease like heart disease, brain disease, stroke disease, etc. And in fact, about 80% of those diseases can be prevented with lifestyle interventions, and almost up to 80% of things like diabetes can be reversed with these lifestyle interventions. But many won't know how much of an impact this has on mental illness. So, you know, exercise is as effective as psychotherapy and medication for depression and anxiety. Diet is can reverse about a third of people with major and severe depression disorder if they eat a whole food, you know, Mediterranean style diet. Social connection is incredibly important. Reducing smoking, again, improves your outcomes as much as taking antidepressants do in things like depression. So there is a massive role for this. And the point I'm simply going to make here is be aware of that and push your GP to refer you or to engage you at this level, because this is so important that these things are adequately addressed and you are supported to do so. Next slide, thanks. This is my website, the GP Show, which is just thegpshow.com, but I have a bunch of resources here for usually health professionals, because my podcast is specifically for health professionals. But I will just say that if you're not getting what you need to get out of your GP, i.e. you want to change your diet, your exercise, smoking, you know, connection, nature connection, etc., which I think is crucial, there are in almost every state now free health coaching services, which are free. So Queensland is My Health for Life, New South Wales, SA, Victoria, I put those 4 states there. You can go to them direct. You don't need to wait for your GP to refer you, and you can start getting health coaching for free. They're like personal trainers for lifestyle. So please use that. There's data from New Zealand who've been doing this, that it reduces prescription rates, increases access, improves mental health. So please start using those services that exist. Next slide, thanks. So when it comes to this partnership, the whole concept here is that these are very basic points, but it's more like a roadmap, and it's about being crucial. It's just give us a bit of a compass as to what 3 questions are going to be really useful and make sure you get the most out of your appointment. And in particular, you get the most out of the partnership. So like this picture, you know, sometimes there are things that we all need to live together. It's a shared decision-making, a shared management approach. And and what can we do to get the best out of you, so to speak. So you obviously need to be fully informed, confident in what's going on, understanding the system, you know, aware. So next slide, thanks. And so the first thing is really just to figure out what our goals are. So and this is not just mental health goals, but this is physical goals, cultural goals, social goals, occupational goals like job, study, spiritual goals, which is incredibly important to some people. And really have a think about what those are. Now, Jan and others did sort of mention this as sort of in passing, but I just want to highlight that, you know, sometimes the goals that we have are not our goals. They're the goals of the people around us, like our family and friends. They're the goals of our therapists. The number of people patients I've had who I've asked them, is this what you want? And they say, no, not really. It's just that the specialist told me I had to do it. I'm like, okay, well then let's talk about what you want out of your care, because you are obviously the most important part of this equation. And so just think about it from a physical health point of view. Maybe, you know, a lot of people telling you might be to lose weight, but maybe you don't care about your weight. Maybe you just want to increase your energy and, you know, vitality. Well, that's a different series of interventions to achieve that. One of the questions in the Q&A, which I'm going to go over time and I apologize, but is about trauma. And so maybe a goal for you is to find a really good trauma therapist or to address that trauma, that complex trauma, which is obviously hugely relevant. And so therefore, that is your goal, and that is the direction you need to take with your GP. So it's very important to identify that. Next slide, thanks. And just think about what are the steps along the way, because sometimes these goals are massive, right? So we've got to sort of break it down into steps along the way, and that's just going to be really important. So maybe to resolving your trauma, which could take many years of pretty intensive therapy depending on the trauma, the first step is simply finding a qualified trauma therapist, of which they are pretty highly specialized professionals. Next slide, thanks. And this has been mentioned too, learn the system a bit, but really, like I said, who can help me and what can help me? And that can be whether it's data, like information, websites, resources, or who, like a professional. So if your goal is to, like I said, more energy vitality, well, then maybe it's a GP, a sleep assessment, a personal trainer, dietitian, someone like that, or maybe it's going to be a resource. And I might mention a couple of resources at the end of this. Next slide, thanks. And then what treatments offer me the most value? And I would just simply say from this is that don't be afraid to ask. I think this paternalistic model of medicine is dying slowly, which is good. And it's turning much more into a partnership-based medicine. And so don't be afraid to ask, what are the options, what are the benefits and what are the risks? And it may be, like for me, I mean, I'm going to honestly say that I don't know the risks to the fine detail of every single treatment, but that's good because then now we can sit down and we can really work it out together. So it does change the dynamic. And yes, and that's different to, I think, how 19th, 20th century medicine was done. Next slide. I think I'm pretty much done. Yep, great. I'm sorry I went a bit over there.
Sam, I'll just reflect for a minute. I remember doing an evaluation of an innovative mental health service, which actually spoke about what their life goals were. And it was amazing looking at the evaluation, how few people have ever, and they've been in contact with mental health services for decades, how surprised people were that no one's ever asked me that before. Like, because part of that was, well, what's one of your goals? And then start to work more systematically to help them achieve some of the goals, which is like getting a license, getting their own accommodation, something like that. And I said, no one's ever asked me that question before. So I'm great that you've sort of picked up on that. In terms of the lifestyle goals though, and in your experience and expertise, what are the ones that you think make the most difference to the people's overall well-being in terms of, because you're obviously an expert in lifestyle medicine. So from your experience, what sort of lifestyle goals or foci really do seem to have the best, bang for the buck, or make the best difference overall to someone's well-being?
I think when you look at the research, there's the most common one is social connection. How well you are connected to people who have similar values to you, whether it's family, friends, peers, colleagues, peer groups, etc. And so I think that can be scary. That's the problem with that, especially if you've got a mental illness and there's obviously social anxieties and everything like that. But this is where you want to talk to your GP and start to problem solve around that, or talk to whoever is in your team and say, okay, I know that it's important, but I'm not sure how to get there. Like there's so many great services out there, peer group support services, etc., that once you just break the ice, you'll start to feel much more comfortable doing. So that's I think in research, it's one of these master factors, social connection. And then from an individual point of view, I think exercise to me, just time and time again, historically, it's the gateway positive behavior, as opposed to a gateway drug, that it just leads to so many things. And so you can do that in your own time. There's so many great YouTube videos now where you can pump out your personal trainer online in your own space. You can go to anywhere you want. It doesn't have to be around people. And it just makes you feel so much better instantly, pretty much. So that's the great thing about it.
Yeah, no, thanks, Sam. I noticed the College of Psychiatry now has, for treatment of depression, physical activity is step 0. And, you know, all the RCTs are showing that it's one of the most, you know, equally effective intervention. And it has so many other great side effects, unlike some of the medications. I'm just going to reflect on some issues and then throw to the general panel. And please, panelists, open your mics and be free. You're the experts. I'm the facilitator, so ask one another questions. But I'll just reflect on your point, Sharon. When I was working as an executive director, someone gave me the advice of the most important person in the organisation to build a relationship with is the chief executive's executive assistant. One day that person will save your butt. So true. And I'm just reflecting on what you were saying, Sharon, and say one of the most important people, and bringing a few threads of this together to build a relationship with, is the receptionist, because they're the ones who can sort of open up slots and sneak you in, etc. And they're often the gatekeepers of you know, quite rightly, the gatekeepers and protectors of the GPs, the busy GPs. So building that relationship with the reception staff at a GP is such great advice, because they're often under the pump too, and often they have irritable patients and customers and carers. So building up a positive, respectful relationship, I think it's a good investment. And I also reflect, then I'll throw it open too, that understanding of the GP practices are a small business. And so understanding that and not asking for extra time when there's not extra time. So, you know, bringing that together, asking for double appointments. I know a number of people have said, you know, flagging the extent of the time so that the time can be adequately recognised and recompensed, because otherwise it's a loss maker. So it's just the reality of it. And I think understanding the reality really helps you to sort of get the best from, you know, best service. But I'm just going to throw to everyone now in terms of the other key things in terms of working with a GP and GP practices, in terms of your experience and the challenges.
I guess I'll just throw in there that issue of continuity of care. Now, when we talk about evidence-based medicine, I think people are quite happy to accept evidence for, you know, certain, you know, medications or surgery or even interventions like exercise. But actually, it's important to know there's actually evidence that continuity of care also gets better outcomes. And I think I find this really hard because I'm a part-time GP. I spend half my time as an educator and half my time as a GP. And so I always say to people up front who come to me, look, I'm only here a couple of days a week. I will definitely give you names of GPs who work like me in the clinic so that there's continuity. But every time you tell your story, I mean, I know that people with lived experience say how hard that is to keep telling their story. But I also agree, I find it really hard to, in a very short appointment, to get my head around all the complexity of somebody's story if I don't know them well. And assuming that I can kind of just see it in the notes because it's there is also it's not as straightforward as that, because there's lots of bits of information in the notes and it's often not well organised. I mean, we try and organise it, but it might not be. So that notion of continuity of care, and I agree, it's very hard if you can't find that GP, but often it's better to stick with the one GP for a little bit longer. And the problems often happen when you go, well, I'm in crisis, so I need to go and see someone right now. And while that's fine for a stopgap measure to get you through a couple of days, in terms of making big decisions like which therapist will you switch to or which medication will you now take, the more your care is fragmented in that way, and the more likely you are to not get the best outcome. That's been my experience as a GP. You know, another GP sees one of my patients and puts them on some drug that I then have to spend 6 weeks getting them off it again, because I remember that we tried that or someone else tried it 20 years ago. And I can't expect my colleagues to know that from one 15-minute encounter. So really valuing continuity to the point that you might sometimes wait a little bit longer and have to be patient. Some of my younger colleagues call this slow medicine, advocating for taking time. Just like with slow cooking, you get a better product when you cook that leg of lamb really slow. It's the same with the relationships you get in healthcare, especially if you've got a condition that's going to take a while to sort out.
And I'd just add to that, Russell, if I may. Lived Experience Australia has just undertaken some research around the missing middle, and what came out very clearly in that was that the GP was the most accessed person for people who had fallen through the gaps. So it seemed to me that the GPs are really the first and the last port of call, really, for mental health issues. And so the importance of having that relationship with your GP, but also understanding that mental health, if you have nowhere else to talk or to go to talk about your issues, the GP is offering that in a very tight, you know, seeing numerous patients about a whole lot of other things other than mental health. And I think it's also fair to say that, you know, GPs may not necessarily want to engage long-term with people with mental health issues. I know a very good friend of mine was seeing multitudes. She became known as, oh, right, your GP, this person has a real understanding of mental health issues. And what happened was that ultimately she had to relinquish the position within her practice as a GP and go on to other things. It was compassion burnout, I think, that I think many of the GPs are aware of. So I think we as patients need also to understand that, you know, the GP is there not just for mental health issues, but also the only place to go for those physical needs as well.
I think Janice brings up a challenging question, is that, you know, clearly there's some, like our panelists are really excellent GPs, and there's a lot of GPs who are mental health friendly, but there's some that are, well, there's some people can't have difficulty accessing a regular GP, and also sometimes in communities, a particular GP might not be as mentally health attuned as others. So what would your advice be about, because there's a few questions about this too, about challenges of getting a good GP. So what would your advice be about navigating this part of the system?
Yes, that's really a really tricky question. And not all personalities fit the mold either, do they? Like, you know, you may feel very comfortable with one GP and potentially not quite so comfortable with another one. And so, look, I mean, I'll be open to hear what Carolyn and Sam say, but I think it's a matter of, if you are in a practice where there are multiple GPs, from my perspective, I like to know that my notes are consistent across a specific practice. So it may be that you need to choose a GP within that practice who has the time, the additional training, and the desire to talk to people more around the mental health issues. But I also say that many people with significant mental health issues actually don't have a GP, and hence that brings up multiple problems, doesn't it, both in the mental health, but also most particularly in the physical health issues. No one is, because they don't access a GP, there's no one providing oversight of the physical conditions which can be caused by the medications, amongst other things, lack of motivation, etc., etc. I'm not sure what the answer to that is, except you would hope that if they are in contact with a mental health team, particularly one in the community, and if there's anyone listening to this webinar or who will access the recording, a GP plays a hugely important role. And so it would, if one of your clients doesn't have a regular GP, I would dearly love to ask that you put yourself out there and find a GP that is able to, at the very least, monitor the physical conditions of one of your clients or your clients. I think one of the main questions you should ask is, do you have a regular GP? And if you don't, then we feel we have the duty to try and find someone for you. If you do, then that's fine. That would be my only answer, I think, Russell.
I can probably add some ideas to that, and certainly thinking from our perspective of GPs retiring, GPs leaving, that transition to a new GP is something that has always been consciously thought about. So, it takes time for the GP to get to know the person and for the person to get to know the GP. So, for me, it was about encouraging my husband. I'll just hang in there, just, give him a couple more visits and get to know him a bit better and see how you go. You can always change, just see how it goes, because it takes a bit of time. And also planning when we knew that the other GP was retiring a number of months before, actually starting to meet the new GP, i.e. the new GP learning to know and understand. So, those transitions, I think, otherwise you just bounce from one to the other and they don't get to know you and you don't get to know them, and how they present on the first contact might be quite different 2 or 3 contacts down the track when they get to know you.
Mm.
And I think at the basis of this, if I might quickly add, trust is the base of all of this. You may feel more trusting with one GP, you may feel in terms of discussing certain issues, etc. And people with mental health issues, historically, trust can be and often is a major barrier to actually being provided or seeking the best possible care.
And if people don't feel listened to, then particularly I notice, people I know with mental health, they will, because their self-esteem is not great either sometimes. And so they'll take it personally and they'll say, oh, I don't want to go back to that person again. It's being sensitive to that and trust, trust is really important.
Caroline and Sam. Thanks, Caroline.
Can I add to that? I mean, I've certainly had patients who have kind of sacked me because something went wrong. Like, normally we send a reminder and the receptionist forgot to send a reminder and they didn't get a reminder. So I rang them and said, where are you? And it's bad for me because, half an hour appointment that's not happening. And that means you're basically just not earning money for that half hour. And the patient's not happy because they're missing out on care for that. It's quite tricky. I'd take a different spin on it as an educator. My life's mission is to actually get more GPs good at mental health. I don't think it's that great to have people saying there are GPs who aren't that interested in mental health. And so I've done a lot of work trying to lift the game of GPs, as people who know me well know. I think, though, in fairness to them, many of them did train in countries outside of Australia, and they wouldn't have had the same exposure to mental health training as I was lucky enough to receive as an Australian trained graduate. So, it is something that they can learn over time. And I think this notion of lived experience and carers, people being able to kind of be articulate with GPs of what they want. I think even those GPs who might not seem that interested probably do still care. They just don't always know what the right style is. And also the fact that there are definitely different styles of doctors for different people. Like I've got patients who find me way too like I say, you've got to make the decision, and they don't necessarily like that. They go, well, what would you do? Whereas there are other doctors in my practice who I would describe as a little bit more paternalistic, but that works really well for some people. They want the father figure who says, do this. So recognizing that it is a bit of a matching game, and that's okay. But also recognizing the system barriers. So at the end of the day, if someone does what I do and puts on my website, I'm interested in mental health, I'm basically, as a business model, sending a message that I'm happy to basically halve my income. I mean, the more mental health work you do, basically, the less money you earn. And I'm fortunate enough that I'm senior enough in my career that I can take that cut. But imagine some young GP starting out their practice, looking at the way Medicare is structured. They might want to help, but they just can't pay the bills. It's as bad as that. And that's why it's a human rights issue. You can't have a system where some people's care is just not valued, even financially. But that's where breaking up the care into little bits and being prepared to come back, especially if you want a bulk billing clinic, they're going to have to see you in small bits of time. So thinking about how you can break up your problem and going in and saying, here's my list of the 5 things on the list. I think these are the 2 most important. Do you agree, yes or no? Let's deal with those today, but I'll come back next week. So even with bulk billing care, if you can break it up into those small 10 to 15 minute aliquots, you can still get good preventive healthcare, particularly good physical healthcare, but you just can't do it all in one big lump at one presentation. It takes a bit of persistence.
Now, Sam, and then I'm just conscious of the time, so I'm actually going to go around and ask everyone in 30 seconds after Sam's had a response to that discussion, to just say, if you could give one piece of advice to a consumer, carer, GP, or a allied health professional about getting the best out of the GP visit, what would that piece be? But before we go to that question, Sam, did you want to come in on that previous conversation?
Yeah, I'll do both. So my one piece of advice is like I said, just be clear on what you want and open that up with your GP. Like from a bio, psycho, social, cultural, and spiritual point of view. I've had lots of patients who the spiritual component is so important that they see a great meaning in their suffering to some degree and they want to go through it. So that's totally fine and respect, and we'll support that. But I can't create a good plan unless I know that. So just as it comes to finding GPs, this is a perennial problem. Access to GPs and enough GPs who are like highly mental health trained. I agree with Caroline. I'm also a medical educator and I spend a lot of time training GPs. But my opinion is that I don't think GP training is long enough. I think there should be at least another year. So you're going to have those deficits that are natural but not intended. So I would just say that, you know, a lot of communities have closed Facebook groups. I find that actually a good way to just say, have you guys found any good GPs who are mental health focused? Like, I find that a good way to find them. Like Sharon said, be patient though, give them time, because it takes a number of appointments just to get to know you, and then to understand the nuance of the problems. I know I've made mistakes in that area. Keep in mind that sometimes, like for me, because of my areas of expertise, inverted commas, I'm people's secondary GP. I'm more like their subspecialist. And so they have their usual GP for day-to-day matters, but then they come and see me once every 2-3 months for that more the mental health thing or the lifestyle thing, and I'm fine with that, and I communicate accordingly. And that last thing is just book ahead. I mean, it sounds like if you think that you can get into your GP on a day's notice, good luck. I mean, you know, and that's sad. It's a sad fact, but it's a reality fact. For me, it's like a 3-4 week waiting list, and but you just have to book ahead and book. If you think you're going to need to be seen every 2 weeks or 1 week because you want to get through this issue, this goal is to achieve this, then book every 1 or 2 weeks. I got no problem with that. I welcome it. So so that's my answer and my summary.
Right, thanks, Sam. So I'll go around the panel. Jan, what's your 30-second piece of advice? Yes,
well, my advice would be, when you go to your GP, go well prepared. So if that's your list, I think that's always really useful so that you can get the most out of your visit. You don't want to walk out the door and think, oh gosh, I wish I'd asked about that, because that could be the most important thing that you should have discussed at the consultation. So that would be my advice. Go prepared.
And Sharon.
Yeah, because it's all about the relationship, I'd probably, as the person going to see the GP, ask them, how was your day?
Right, certainly get their attention. Well done. And Caroline.
So my advice would be, if you're experiencing a mental illness, don't underestimate how attending to your physical health will help you feel better from a mental health point of view as well. It's so easy when you're very distressed. Not easy, it's very hard. But being distressed means it's natural to not prioritize physical health. But if you're not physically well, then your mental illness will be that much harder to deal with.
Mm-hmm. Thank you. I was put under the pressure to sort of summarize this, but I think this group has done a great job of saying, you know, the importance of being prepared, understanding the GP practice and the complexities of that, but also the importance of building a relationship and being proactive in building a relationship with the GP practice. And then also, when you go there, being clear about what goals are, like what are your life goals, but what's the goal of that visit? And finally, you know, everything about equally well, you know, attend to your physical health, because you look after your physical health, it's going to help you at your mental health as well. So I just want to thank you all, Jan, Caroline, Sam, and Sharon, and everyone attending. I think it's been a really great contribution, and I'm looking forward to this being posted, and at least promise it will be posted hopefully later today, but certainly by the weekend it'll be available with the recordings, as will all the links in the chat. So I just want to thank all of our panelists and all of you, and thank you and good afternoon.